Morning. I'm Beth McCarthy, the Director of Specialized Geriatrics at Parkwood, and I have the honor of introducing Dr. Barbara Luke this morning. And when I say honor, I was at the table saying, I'll do that, right at the very beginning, because it is truly an honor to have her here in London with us. Dr. Luke's name has become synonymous with senior-friendly care across Ontario, across Canada, and actually internationally. She graduated from the Faculty of Medicine at the University of Toronto in 1987 and went on to specialize in geriatrics soon after. Many of us have come to know her through her role as Executive Director of the Regional Geriatrics Program of Toronto, located at Sunnybrook Health Sciences Centre, and the leadership that she provides at our provincial tables around issues specific to the care of the elderly. However, she is kept busy holding many other roles as well. Associate Professor with the Department of Geriatric Medicine, Department of Medicine U of T, and a cross-appointment with the Division of Clinical Pharmacology, Department of Medicine U of T. And of course, a consultant in geriatric medicine at Sunnybrook, where she continues to see patients. Last year, Dr. Liu was elected a Fellow of the Royal College of Physicians of Edinburgh. It's a highly respected international standard of clinical excellence, and quite a privilege to be elected to that position. She was nominated by 2 of her peers for this fellowship. Dr. Liu is also recognized across this country for her leadership to the Move On program, Mobilization of Vulnerable Elders in Ontario. This program aims to ensure seniors are encouraged, helped, allowed to get out of their hospital beds to stay as active as possible while in hospital. She's been quoted as saying, it's just not good for them to stay in bed. Today, Dr. Liu is here to share her ideas with us on how to build and sustain senior-friendly practices across Ontario. Dr. Liu truly believes in this work we are doing, and we're so fortunate to have that she was able to take time out of her busy, very busy schedule today to travel to the Southwest to be with us. Please join me in welcoming Dr. Liu.
I am very honored to be here in Southwest Lynn. I'm going to share with you some information about the Provincial Strategy, there we go. So we're going to just very briefly go over the senior-friendly hospital framework and the strategy to date. I'm going to share with you some of the preliminary, I feel like there is too much happening. Yep. Share with you some of the preliminary information about the indicator evaluation, and 3 of the hospitals in this Lynn contributed to that indicator evaluation. And then spend some time talking about senior-friendly hospital and how it aligns with other things happening in the system. Where are the synergies? What are the opportunities to support sustainability and future steps for the strategy? So in terms of the context, everybody knows that we spend a lot on healthcare, and that if you split that healthcare budget up into the pieces of the pie, that hospitals make up the biggest piece of that pie. I've actually heard a lot of people say, not a lot of people, but some people say, and some influential people say, well, you know, seniors shouldn't be coming to the hospital anyway. You tell me it's dangerous, they should just stay out of the hospital. We need to invest more money in the community. Let's stop talking about senior-friendly hospitals. Let's talk about senior-friendly communities. And I say that's 100% true. We need to have more community services and support for seniors so that they can stay out of the hospital. But no matter what we do to transform the community, the idea that hospitals would only be a resource for younger people is an unrealistic and a ridiculous concept. When people get sick, they are the most vulnerable. They're at their peak of high risk. And many of those people will be older, despite the fact that we boost up the community services for seniors in the healthcare system. So hospitals are obliged to become more senior friendly, because if it is the largest part of our investment in the healthcare budget, then it's a responsibility for us to ensure that those dollars are invested in a system that is going to be senior friendly to optimize outcomes and minimize the risk for older patients when they do need the resources that can only be offered in the hospital setting. So you saw the framework. There are 5 components: the processes of care, emotional and behavioral environment, ethics and clinical care and research, organizational support, and the physical environment. And we'll come back to this framework later on in the presentation. So where have we been since 2010? We've been through 3 phases, and the strategy is still ongoing. In the first phase, we did the hospital environmental scans that Jillian referred to. So 155 hospitals completed that self-assessment. And one of our future next steps that will be coming in the summer is that there is going to be a refresh of that environmental scan. So hospitals will once again be asked to do a self-assessment survey. It'll be much more focused and narrowed down in terms of its scope, so it won't be as big a chore for hospitals. But it is time. As Jillian said, there's been significant progress since the first scan, and we need to know where things are. And we also need to know where the pockets of excellence are that are happening around the province so that we can gather up that information and disseminate it more widely. In phase 2, we identified promising practices and created a toolkit to help organizations with their improvement plans. And phase 3 was the identification of indicators and evaluating the potential implementation of those indicators. So the 2 priorities that were identified for the strategy were to prevent functional decline through interprofessional early mobilization strategies, and the second priority was to prevent and manage delirium, again using interprofessional approaches. And I'll come back to both of these priorities with examples a little bit later. To help organizations with those priorities, as I mentioned, there was a toolkit with resources that were identified through an evidence-based process. They had to meet certain criteria. There was a vetting through an expert panel that included participation from all over the province and from people with different ranges of experience. So clinical experience, research experience, educational experience, and representation from large organizations as well as small organizations. And I think that's very important. I really want to emphasize the fact that even though I am from Toronto, I like to think that I am familiar with the fact that Ontario has very varied contextual settings in terms of urban and rural and within the healthcare system in terms of the hospitals. So there are several hospitals that are very, very small, especially in the 2 northern limbs, organizations with 10 beds and 3 full-time staff, and senior friendly is just one part of their multifaceted portfolio. Comparing that and working in that context with some of the mega hospitals that you see in the large urban centers like in London and Toronto, and making something that is going to be meaningful to all of those different settings was at the forefront of the work that we engaged in this process. Next, we looked at the indicators. So this again was a very evidence-based process because we wanted to hold the bar quite high. We said, let's develop indicators, or let's identify indicators that potentially could be used for accountability purposes. So that would be the most robust process that would be required. If a hospital was going to be held accountable to performance against these indicators, we needed to be pretty darn sure that we had done due diligence in identifying those indicators. It wasn't just a group of people that said, this seems like a pretty good idea to me. We went through a very rigorous process. There were over 15,000 articles identified that were relevant to either delirium or functional decline. From the 15,000, we narrowed down the field to about 600 articles that we actually reviewed in full. From those 600 articles, we pulled out over 700 potential indicators. So these were things that were published in the literature. Plus, we asked the hospitals in Ontario, which indicators are you currently using that are relevant to these 2 priorities? And they sent us an additional number of indicators. So then we sat around the table and looked at all of those indicators and honed down the list. And again, it was a very inclusive working group. from all over Ontario, large and small, and for a variety of different backgrounds in terms of area of expertise. And then they voted. They used a Delphi voting process and voted on the validity and reliability, the feasibility, the responsiveness. Was this indicator going to be responsive to change? Was it easy to report? Was the result of the indicator clear? When I told you a number for that indicator, was it sending a clear message? Did you understand what it was trying to tell you? Was the indicator going to lead to actionable change? And was it considered clinically appropriate? Was it something that was relevant to clinical practice? And we came down from those 15,000 articles to 2 indicators for delirium and 2 indicators for functional decline. So the 2 indicators for delirium, one is a process indicator and one is an outcome indicator. A process indicator is looking at the percentage of patients that receive delirium screening within 48 hours of admission to hospital using a validated tool. And the tools were the tools that we identified in the toolkit, in the resources in the second phase of the project. But all of the organizations chose to use the CAM, the Confusion Assessment Method. So that is most definitely the front runner in terms of how to screen for delirium. The outcome is the incidence of hospital-acquired delirium. So the percentage of patients that go from a negative CAM at admission and become CAM positive at some point during their admission. They have new delirium. We're not counting the patients that come in with delirium because the hospital can't be responsible for the people that arrive with delirium. But we want them to be responsible for stopping people from becoming delirious while they're in the doors of the hospital. So this is like a hospital-acquired complication, just like bed sores or infection. So for functional decline, this was only applied to the acute care sector. So rehab was not expected to apply an indicator like this. They've already got indicators for outcomes in the rehab sector. They've got their FIMS that they have to report to CIHI, and they're mandated. They also have mandated timelines, so we weren't going to conflict with those things that were already in place in the system. So the process is the percentage of patients that receive an ADL functional assessment at baseline and at discharge. So within 48 hours of admission and 48 hours of discharge. And the outcome we were looking for was the percentage of patients that remained stable in terms of their ADL function or improved. So we did not want to see patients having decline. And we'll come back to some of the issues with these indicators when I share with you some of the preliminary results. So here they are, some of the preliminary results. So 42 hospitals and 10 LHINs volunteered to evaluate these indicators, which was an overwhelming response for us. We were thrilled that so many hospitals were willing to embark on this journey with us with no additional resources. The purpose of the evaluation was, as I said, to inform whether it's feasible to implement these indicators and what were some of the pitfalls that we might encounter if these were put into widespread use. So we're looking at feasibility, the definitions for the indicators, the clinical value, and whether there were any implementation strategies that were particularly helpful or, as I mentioned, any pitfalls in implementation. So the participating hospitals, 42 hospitals, 3 are from the Southwest LHIN that are at the top left corner there, the Grey Bruce, St. Joseph's, and St. Thomas Elgin General Hospital. And thank you to those organizations for participating. Are there any representatives from those organizations here? Very good, thank you very much. So for the delirium indicators, 31 hospitals in Ontario evaluated these indicators for over 6 months. And it included over 1,000 beds. So what we found in terms of the process indicators, so screening with the CAM within 48 hours of admission, we had very high rates of compliance with this, and even though they were high to start with, the compliance increased even further over the course of the evaluation. Qualitatively, the staff told us this tool was easy to use, it was quick for us to learn, it was feasible in terms of the demand on the clinical staff. Concerns were raised about one of the criteria reflecting the acute change in the person's status. And in order to assess the acute change, you had to have some information of what their baseline was like. So it needs to be possibly coupled with additional information about the patient's previous status cognitively. There was clear feedback that there was a need for training, that people, even though it's easy to use, need to be oriented to this tool, and that would be true for any tool. But in particular, when you're applying this tools to certain populations, like patients with communication difficulty, aphasia, or patients with pre-existing dementia, as I said, to understand what their baseline was versus what you're seeing now. And then in terms of the inclusion-exclusion criteria that we offered, we thought it was feasible, would optimize the feasibility if we excluded patients who were deemed palliative from having this tool applied to them. But actually organizations told us that they felt that that was inappropriate, that delirium and end-of-life care was a clinically important condition and that we needed to identify those patients as well. In terms of the outcome, there was again high compliance with regular CAM screening. So to identify new onset delirium, you need to have regular screening at intervals through the hospitalization. We recommended at least once daily. And hospitals were able to do that. They were able to do it once daily. Some organizations were doing it Q shift. What was a challenge was for organizations that were using paper-based charting to abstract that information at the end. So you're doing it every day. In order to determine if someone went from negative to positive, you had to flip through your paper chart and look at every day's CAM result. So clearly this was something that needed to be addressed in terms of widespread implementation. The issue of the frequency of CAM screening was also raised for the non-acute sector. In the rehab and CCC sector, they felt that doing it every day wasn't necessary. These patients were more stable and they weren't seeing that the changes happening every day. We've had some preliminary discussions on this, and I welcome your thoughts on this. And we felt that it was still relevant to assess every day in this sector because of two things. Number one, if delirium happens, you don't want to wait a week before you identify it. So hopefully it's not an issue of relying on the CAM screening to identify delirium. Hopefully clinical awareness will be heightened as well. But having that process in place ensures that it would be done on a regular basis and that thinking would be happening on a regular basis. The other thing was something that Elaine mentioned, and that was assess and restore. And the landscape of rehab and CCC is likely to be changing in the near future as assess and restore rolls through and as senior-friendly hospital informs that process. So the types of patients that are going to be in rehab, CCC, and in those types of beds may be people that have maybe a higher proclivity to delirium than we have accepted in the past. You know, in the past it was like medically stable, no evidence of cognitive issues, no delirium. Well, now the system is shifting in a direction that maybe the patients with delirium could be managed in the rehab or the CCC sector. So reliability and validity is also an issue. So as I mentioned, the process to identify these indicators was rigorous. These indicators, the CAM has been evaluated in the literature to have high sensitivity and high specificity. We know that the tool is a good tool. Translating that into real-world application, however, can compromise some of the validity and reliability. So we did get reports that clinicians felt that there was a moderate degree of questionable validity and reliability, that inter-rater reliability might vary depending on an individual's comfort level, clinical experience with the tool, and also validity was also something that needed to be enhanced in terms of against a gold standard. So sometimes the CAM was coming out negative, but the clinicians clearly felt that the person was delirious. So there needs to be education, training, and an audit mechanism to compare it to the gold standard. So overall for delirium, we can have high rates of compliance. Daily screening is also feasible, and it was also felt to be extremely valuable in stimulating clinical change. People were doing the screening and then saying, now what do I do? And so the natural process of having implementation strategies followed suit, and that organizations were making positive changes in their process by virtue of implementing the measurement tool. It also provided an important opportunity for provincial collaboration, which is also what this day is all about. So by implementing the indicators and doing the evaluation collaboratively across Ontario, we brought together several organizations that are now sharing tools, looking at different strategies to improve their delirium prevention and management. So for functional decline, we had 21 hospitals with over 600 beds evaluating tools to monitor functional decline. The first tool was the Barthel. The Barthel, I showed you the elements of the Barthel on the lower right of this slide. 11 organizations looked at the Barthel, and our target rate of compliance was 80%. We had more than half meeting that compliance rate, but it was still less than I was hoping for. 56% of organizations were able to meet the target of 80% compliance. Most clinicians said it was very easy to use. It was also used interprofessionally. PSWs can use the Barthel. And it was felt to have good sensitivity, that it was identifying change and improvements in patients that were clinically relevant for the acute care setting. The HOBIC, on the other hand, was the results were less promising. So the compliance was low. Are any of the three organizations from Southwest Lynn here, were any of them using the HOBIC? Did any of you participate in the HOBIC evaluation? No. Okay, so that's good. Because the HOBIC has been in Ontario for some time, and there's a lot of investment, in terms of work and effort, but a lot of emotional investment in this tool. And I know that some people have dedicated a lot of work to promoting the HOBIC, and I'm sorry to have to be the person to report this, but the organizations that have that participated in this evaluation with us reported that they felt that HOBIC was very cumbersome, that it was very time-consuming, that they weren't getting information back at the point of care that was going to influence what they were doing with the patient. So they felt that it was more of an exercise in data collection as opposed to influencing care. So that's not a good place to be in terms of clinical value of data collection. Overall, for functional decline, we had high compliance rates with ADL assessment as long as the tool was easy to use. Between HOBIC and Barthel, it was clearly the Barthel was easier. The other tool that we had suggested that organizations could use was the AlphaFIM. AlphaFIM is used for the stroke initiatives or the stroke patients, but no organizations wanted to pay the licensing fee for the purposes of this evaluation to use the AlphaFIM on non-stroke patients. But I think that AlphaFIM, we just don't know whether it's feasible in this population, but it potentially is because it is another simple tool. The goal of monitoring patients' functional decline during the course of hospitalization is predicated on the ability to have an admission and a discharge assessment, and the discharge assessment is extremely challenging. It does not appear feasible to collect the discharge ADL assessment because at the point of discharge, so much is happening that the documentation is not happening. Our rate of compliance for the discharge ADL assessment was very low, in the range of 20, 30, 40%. So it clearly did not meet the bar of 80%. For longer stay patients, it is potentially feasible to monitor ADL at discharge, and those longer stay patients, it was actually felt to be clinically of value to monitor them and to get positive feedback to the staff that their ADL status was improving. And just one opportunity that we were quite thrilled to hear about was that after implementing the Barthel, one site decided to use the Barthel in their post-discharge follow-up, because the Barthel has also been validated for use by telephone. So it's been validated for use by PSWs as well as on the telephone. So I'm about halfway through my slide deck, and I presented you with quite a bit of information. This is how some people might be feeling at this time. Just a little bit, kind of sleepy and overwhelmed. But does anyone know what kawaii means? Kawaii is the Japanese word for cuteness. And in Japan, the love of cute things is really a cultural phenomenon. And so you can see all of these pictures of cute animals. But my goodness, why is Barbara Lynn talking about cute animals in the middle of the senior-friendly hospital presentation? It's because about halfway through a 1 hour talk, people's attention really starts to wane, and that's when people usually throw in the joke, or, you know, the cute comics line. But as my husband will tell, my husband is Irish, and he says, you cannot tell a joke if your life depended on it, and you know, it's so true. Whereas his Irish background, you know, the jokes are just rolling left, right, and center. So I can't do jokes, so this is my attention grabber, it's the Kauai. But there's actually an evidence base behind Kauai and why I am showing you this. So in controlled trials for workers, if you show them pictures of baby animals, their performance on attention requiring tasks improves in the post phase. So after you look at the pictures of the baby animals, your attention and concentration improves on tasks. If you show them pictures of regular adult animals, no improvement. You show them pictures of food, no improvement. But the baby animal pictures work. So let's give ourselves a dose of Kauai and increase our attention. And in particular, I like this little kitten on the bottom who's like praying up there, please help me to make my organization more senior friendly. So now we're going to move on to alignments, synergies, and sustainability. So as Elaine mentioned, the Living Longer, Living Well, the senior strategy, the SINHA report. So clearly there is an alignment here. And I was very glad to see in this report that there was an entire chapter dedicated to improving acute care for elders. And all of the recommendations in that section are very much aligned with the work that is happening under the Senior Friendly Hospital Panlin strategy. So we're in a good position there. The other place that is happening provincially, the other initiative that's happening provincially is Assess and Restore, that is also embedded within the SINHA report. And some of you may have seen this figure. If you haven't seen it, you will see it, I think, a lot in the coming months as Assess and Restore policy is finalized and rolled out. So just, you don't need to see, understand what the elements are here, but to orient you, Assess and Restore is the red upside down L-shaped box. This whole thing is supposed to represent the system, and this movement through the system in this L shape is supposed to be representative of Assess and Restore. And central to the whole L-shaped Assess and Restore movement is senior-friendly hospitals. We are positioned right in the center of that. So it's clear that senior-friendly hospitals is a foundational element for Assess and Restore. And senior-friendly hospitals, I think that framework is foundational to just about everything in healthcare that's related to seniors. So let's talk about some specific initiatives that have happened in the province aligned with Senior Friendly Hospital. One is Move On, the mobilization of vulnerable elders in Ontario. And I'd like to acknowledge the funding that was received from CAHO, the Council of Academic Hospitals, to make this, to help us disseminate this to a total of 14 hospitals in Ontario. But there are many, many other organizations that are not participating in the data collection, that are also implementing early mobilization. So you all know about the complications of immobility, and a lot of this is familiar to healthcare providers. I think the thing to point out that many healthcare providers don't recognize is that bed rest is also associated with psychological adverse effects. It can be associated with anxiety, depression, sensory deprivation, learned helplessness, and of course delirium. A lot of the evidence for the effects of immobility come from the SPACE program, studies that they have done on young healthy people and the effects of weightlessness and lying in bed for prolonged periods of time. But in fact, it doesn't take a prolonged period of time in an older person. So for these young people that are at the peak of their physical fitness, these are the most robust physical specimens that we have on the planet that we can shoot up into space. And for these people, it may take some time before they lose enough muscle mass, but by the time they come back to gravity, they are not able to walk. When they land on the ground after the capsule hits, they have to be carried off by people on a stretcher. They are unable to stand and unable to ambulate. So those are physically robust young people. Think about what's happening with our older patients when they come to hospital. They may be at the threshold of being able to transfer independently or walk before they got sick. It's only going to take a matter of 1 or 2 days before they're no longer able to generate enough motor movement in order to do a transfer or to walk. And of course that is like the rate limiting factor for discharge. If they can't get up and walk, then it's not going to be feasible for them to go home. So the key messages behind mobilization was that we needed to, within organizations, encourage mobility 3 times a day. Mobility does not mean ambulation. It means mobility to the maximum capacity of that individual for that day. So that may be getting up to the chair, it may be range of motion. For some, it may be ambulation. That mobilization should be progressive and scaled. So each day you need to reassess what the mobility potential of that person is and reach for the maximum that they can do for that day. And that assessment should begin within 24 hours of admission, not at the point of discharge when you suddenly find out that the patient isn't able to ambulate. I could add a 4th key message here, and that is that mobilization of older patients in hospital is an interprofessional responsibility. It is not the responsibility of a single health professional group, and the group that is traditionally associated with mobilization is physiotherapy, but we, through this initiative, wanted to distribute that responsibility to everyone who contributes to mobilization of older patients. So the intervention was educational, education of staff, clinical and non-clinical, as well as patients and family. And organizations use all sorts of different methods to deliver the education. What we saw was a significant improvement in the rate of mobilization during and post. I can't share with you the exact results. This is preliminary because we haven't published the results yet and we're still doing more analysis. But this preliminary result, I believe, is a conservative examination of the data. So I've asked the statistician to go back and do some more nuanced analysis. But we are optimistic that the results will be even better looking than this. At an individual organization level, the results were not always positive. And I think there are lessons to be learned from that as well. So, you know, what was it that was happening in that organization that was different than the ones that were able to achieve a positive result? In terms of length of stay, of course, there were other things happening in the system at the same time as our initiative, but we needed to ensure that length of stay was not increasing as a result, and length of stay was, over this period of time, going down during and post-implementation. And staff perception was very positive, so there was a sense of improved interprofessional teamwork, a sense of shared responsibility, that other team members that weren't traditionally involved in thinking about mobilizations were now incorporating it into their practice. Social workers would now say, let's go for a walk down the hall and we'll talk to you in the common room. The pharmacist might say, let's get up into the chair while I talk to you and counsel you about your medications. So everyone was thinking more about mobilization, and a common language was a facilitator in that. So everyone understood what the patient was able to do in terms of their mobilization. And the other important shift was dispelling the concept that I'm sick, I need to lie in bed. So that was both on the part of the staff, but also, importantly, education for the patients and family to ensure that they understood that lying in bed was not the best treatment option for their family members. So several of the success factors were that stakeholders needed to be engaged in any type of initiative rolling forward. Think very carefully about the stakeholders and who have you engaged and who have you left off your list, because it never fails that despite all of your best planning, there's somebody that you forgot to talk to that turns out to be key. Defining roles of planning intervention, I think it's important to emphasize that planning phase is long. It takes time to get ready, and to roll out quickly and in a rush, I think is something that compromises some of our initiatives. And considering sustainability, which is what you're here to talk about today, needs to happen right from day one, is how is this going to be sustained after the initial rollout. And some of our key enablers are listed there, and I think probably the most important one is alignment with the senior-friendly hospital strategy. That MOVE On was was happening at the same time as the strategy so that organizations saw the direct link. The other piece is the experience that we had with collaboration and interorganizational collaboration, but maybe at your organizations, what you should be thinking about is your experience with interprofessional team collaboration and teamwork. So to apply it to that setting is looking at what is happening at that unit level in terms of the interaction. Acknowledging that there were several organizations participating. And then moving on to the second priority, so this is delirium, or the other priority. I shouldn't say that one is first and one is second, but the other priority is delirium. So where are the alignments for delirium? The Ontario Coroner's Report was released in the winter of 2013, I believe it was, and there was a case of a patient who had frank and prolonged delirium in hospital. And even though the patient's medical care was reasonable, like all sorts of complications happening in hospital, what the coroner's report focused on was the fact that this patient's delirium was not adequately addressed and that there was distress that was experienced by the patient throughout this hospitalization, as manifest by his behaviors and difficulty with staff managing him. And so the recommendation was that something needs to be done in Ontario about better management of delirium, and the coroner had a series of recommendations, and one of them was to promote senior-friendly hospital, so that they asked the hospitals to commit to that, as well as the LHINs. And the LHINs submitted a response to the coroner's report that highlighted the senior-friendly hospital was supporting these recommendations. Another external alignment is Accreditation Canada. So we have submitted a request to have delirium included as an ROP for organizations in their accreditation process. And we're waiting to hear back from Accreditation Canada in January 2015, which is when their next cycle of reviews will be taking place. And then another alignment is the BSO and the initiatives of the Alzheimer's Society. So the Alzheimer's Society is embarking on some initiatives to look at dementia care in the hospital setting. How do we make the hospital setting more favorable in terms of care provided when patients with dementia are admitted? So clearly that is a direct alignment with senior-friendly hospital initiatives. So some of the things that we're doing locally at Sunnybrook, again, working from the experience of the Mobilization initiative, which is, we started it at Sunnybrook, and that's where it spread out to the Move On initiative, is using that same framework to apply to delirium prevention and management. We also have an initiative for antipsychotic stewardship, similar to the antimicrobial stewardship that has been implemented in many organizations. We're just starting out on that initiative now. And we've also had widespread education around responsive behaviors in the organization. So again, we have a lot of enabling tools and resources that we're happy to share. But let's look at what our sustainability challenges are. So we have these great initiatives, a lot of enthusiasm, and many of the things that you probably had from the event last year. You feel inspired, you're motivated, and that's how people feel at the beginning of the initiative. And then the sustainability part becomes much more challenging. So I am not by any means an expert in QI or knowledge translation or systems approaches. I just share with you my experience from trying to do things and where reflecting on what worked and what didn't work, and also working with and talking to some of my colleagues who are experts. So people like Sharon Strauss, who is the head of knowledge translation at the Lee Cushing. Kaveh Shojania is an expert in QI, and he has an office down the hall from me. So, what I share with you is just me as a clinician that's tried to do some of these things and what's worked and what hasn't worked. So some of the things that I've seen in our organization and firsthand is initiative fatigue. So there are too many things happening on the floor, and sometimes you have an initiative and the people on the floor that you're working with say, when are you moving on? When are you leaving us? Because, we've been doing this for a few weeks now, and, it seems like enough. I said, well, we're not leaving. We're here for the long haul. This is what it's going to be. And they look shocked. Like, they're used to one initiative rolling through and then the next one coming on, and So there's a constant ebb and flow of different posters going up on the wall and coming down. So we really need to organize some streamlining of priorities in the hospital sector in terms of longer-term commitment to really realize change and also sustain that change. So I think that is something that we need to address as a system, and in terms of the hospital leadership, honing down the list of things that you want your organization and your frontline staff to address. Part of the way we can do that is to look for alignment. So look for the signals from other things that are happening that are going to be identified as priorities and align with those priorities so that we're all pointing in the same direction. And seek out and nurture productive collaboration. So things that can help us to make this a success is to look out for things like RNAO best practices and best practice spotlight organization initiatives, and making sure that all those things are aligned within the organization. The other sustainability challenge is having all of the low-hanging fruit picked off the trees. So we always think about, when you start out on something, where's the low-hanging fruit? We want to see immediate results. We want to have a win-win. And that's excellent way to get things started, and it helps to really bolster the initiative to get some early wins and positive results. But once you get that low-hanging fruit picked off the tree, the higher fruit is much harder to reach. So then you get into this phase where you're not seeing change. You had your initial successes and now you're plateauing, and that is I think a vulnerable place for an initiative, a vulnerable place for a team that is trying to lead these types of things. So I try to help our team by saying, let's stay focused on making small improvements. The improvements that we saw at the beginning were excellent, and now we're in a different phase of the initiative, and it's going to be smaller changes that we're going to see. From my own experience, it's tempting to fall into a position of, well, they just have to do it now. We've given them the tools, we've given them the education, they have to keep doing it. Now we're reporting this to senior leadership, and we can't let them off the hook for this. And that is not a good thing. So we've often talked about the bottom up and the top down, and that's what this little girl is trying to show us in terms of, getting her things the other way around. So we often say that getting the things started, having that frontline or ownership of the initiative, the bottom up, is really what gets the initiative off the ground. What then gives it that rocket boost is when top down gives us the support, right? When the senior leadership gives us that signal, this is really important to our organization, I'm going to help you achieve your goals. And then all of a sudden, wow, things are really happening. That bottom-up team is really thrilled and exhilarated. They got recognition, and barriers are being broken down because senior leadership is involved. Then you get that plateau where the results are starting to stabilize. And it's tempting to then say, well, senior leadership really wants us to do this. And you keep going back to your frontline staff and saying, senior leadership really wants us to do that. That, to me, in our experience, didn't work. That became a top-down, you just have to do this, what are your numbers, what's happening, why aren't you improving? And that was, for us, not a successful strategy. What we, I think, should have done, are doing, is reigniting the bottom-up at that stage. So it's the bottom-up, top-down, bottom-up, top. I think it might be a bit of a sine curve over time, which also speaks to the fact that context is critically important. So when we start out on improvement initiatives, we often talk about contextualizing the intervention. So when I showed you those enabling tools, like the slide with the different algorithms and the cards and the posters and things, organizations take that and use what they want, implement it how they want, whatever works for the context of where they're implementing. So what I mean by that is that it's the organizational culture, the unit culture. So taking it right down to the unit of implementation. What is the culture? Who are the opinion leaders? What are the resources that you have? Are your staff more senior staff? Are they more junior staff? What are the other assets that are available to help you with this implementation? You contextualize it to the unit of implementation. What kind of education do our staff like? Do they like e-learning? Do they like classroom? Do they like one-on-one? You contextualize it. Well, the same thing is true with looking at sustainability. So the context has evolved from when you started. You have to keep re-examining the context, and that's what I think sometimes people forget, is that things have changed since you started. Stop and have a look at what you're doing and recontextualize your intervention. Because not only have you changed the knowledge base of your staff, other things have happened in the system, and you're at a different stage in your initiative. So the fact that your initiative rolled out onto the floor is part of the contextual change. So that, I think, is a really important thing, is to pause, to think, reflect, and readjust your strategy, readjust your tactical approach. So sustainability of senior-friendly hospital has to be more than a series of initiatives. So that, I think, is part of the way that we think, is that I'm going to roll out this initiative onto this floor, and then sometimes people think, well, I've rolled it out, I'm done. But of course, the sustainability is the big part, but it has to be more than just a series of initiatives. I don't think we're going to have the kind of transformational change in hospitals if we think about it as just an initiative to change a process of care. And this is what brings us back to the framework. So the framework has the 5 elements. We have the processes of care, which would be functional decline and delirium, the interventions to prevent and manage functional decline and delirium. If we look at those as the targets, we have things that we do in that area. We want to screen and detect. We're preventing and managing, we have protocols for that, and we want to monitor and evaluate. But what else is happening with the rest of this framework? All of these other elements that are hanging at the top of this slide, we need to bring those in, activate them, in order to support the target of functional decline and delirium. So we've got the target in the process of care. We need to look at how the other elements of the framework are going to help us achieve those goals. The other way of looking at it is to take that framework and say, okay, what am I going to do in this element? What am I going to do in this element? What am I going to do in this element? And my personal feeling is that is a useful exercise, but it is more productive and more meaningful for the staff as well as the organization if you use the framework in a way that is targeted to a specific goal. So I've seen it done both ways in different organizations, and I've spoken to people in other countries as well that have been trying to implement senior-friendly hospital initiatives. And I think overall that this is a better fit for organizations in terms of identifying the target and then getting all of those elements of the framework rallying around those targets. So you may have different committees, so like the physical environment. What are they doing that is going to help with early mobilization? Clear the clutter from the hallways, get rid of the shine on the floors, ensure that the lighting is adequate, get rid of the tripping and fall hazards in the room. What are they going to do for the delirium? Many of the same things. Reduce the noise levels on the units. Look at different strategies for signage and orientation. So all of those elements are senior friendly, and if you give them a specific goal, something tangible to work towards, I think that the work becomes more real, that things actually start to happen. So looking at that framework again, all of those elements are critically important. We have to put them together. If we have initiatives that are only focused on the process of care, I don't think we will have success for creating a senior-friendly hospital. So what's next? The indicator evaluation report will be available in September. That will be submitted to the LINS, and we will advocate with the LINS or recommend to the LINS action for the next steps in terms of what should be done for the 4 indicators. We're going to continue to advocate with the Ministry, the LIN, and HQO to have senior-friendly hospital indicators included in future accountability or QIP monitoring mechanisms. As I mentioned, we're going to refresh the senior-friendly hospital environmental scan, so that should be coming out in the late summer. And some good news that you'll be able to read about in the newsletters that are on the tables is that we were just recently funded by the Ministry of Health to deliver a senior-friendly hospital advanced practice leadership program. So in Ontario, we'll be asking for applications from organizations to nominate 2 representatives from their organization to participate. in this educational initiative that will marry senior-friendly hospital with QI best practice and develop the skills of those representatives to take back to their organization and serve as leaders for senior-friendly hospital change. As I mentioned, Accreditation Canada will be hopefully getting back to us in January 2015. And we have our collaboration through the Senior Friendly Hospital Indicators evaluation sites, the 42 hospitals that are participating in regular collaborative webinars. And we're going to be expanding that so that more organizations can join in to benefit from the learning and the sharing that's happening there. And just like we did with Mobilization, expanding it from a single hospital to 4 hospitals to 14 hospitals through KHO funding, I'm hoping to secure additional funding so that we can have a multi-site collaborative initiative for Delirium. Even if we don't get funding, I would like to gather up people who are working on Delirium so that we can do things in a coordinated way and evaluate some of the impact on a larger scale. So I know that there is lots of excellent work happening in Delirium in the province, and I would like to create a forum to bring those parties together. So there are lots and lots of people that have contributed to this body of work. I'm very fortunate to be here to share it with you, and I'd just like to make sure that you realize that there are lots of people behind this, and I'd like to thank all of them. So I will stop there, and I welcome any of the questions or comments that you may have about the work.